Piriformis syndrome, often abbreviated as PS, is a condition that many people and even clinicians tend to overlook. It's a neuromuscular disorder where the piriformis muscle, located deep in the buttock, compresses or irritates the sciatic nerve. This can lead to pain not only in the buttocks but also radiating down the leg, closely mimicking other conditions like lumbar radiculopathy. In this video, we'll explore why piriformis syndrome is so often missed, the challenges in diagnosing it, and how modern imaging techniques are changing the landscape for patients and doctors alike. Let's start by understanding what makes PS unique and why it's frequently confused with other causes of gluteal pain. Piriformis syndrome is characterized by pain in the buttock region that often radiates down the leg. The root cause is irritation or compression of the sciatic nerve by the piriformis muscle. This pain can be aggravated by certain movements or postures, such as sitting for long periods or rotating the hip. Interestingly, PS can affect anyone regardless of their occupation or activity level, but it's most common in people in their 40s and 50s. Women are more frequently affected, possibly due to anatomical differences. Understanding these basics is crucial for recognizing the syndrome early. Studies suggest that piriformis syndrome may account for 5% to 8% of low back pain cases. However, its symptoms often overlap with other conditions like lumbar radiculopathy and sacroiliitis, making it difficult to distinguish. This overlap leads to frequent misdiagnosis, with many patients being treated for other ailments before PS is considered. The pain is typically worsened by sitting or hip movement, which can further confuse the clinical picture. Recognizing these overlapping symptoms is the first step toward accurate diagnosis. Piriformis muscle is attached to the front of the sacrum and inserts on the greater trochanter of the femur. Its close relationship with the sciatic nerve is what makes PS possible. In most people, the sciatic nerve passes beneath the piriformis, but anatomical variations exist. Sometimes the nerve may pass through or above the muscle, increasing the risk of compression. Trauma to the buttock, such as a fall or direct blow, is a common trigger, with about half of PS patients reporting such a history. Understanding these anatomical details helps explain why symptoms can vary so much from person to person. Patients with piriformis syndrome typically experience deep buttock pain that may radiate down the back of the thigh and into the lower leg. The pain often follows the path of the sciatic nerve, making it hard to distinguish from classic sciatica. Activities like getting out of bed, sitting for long periods, or rotating the hip can make the pain worse. Some patients also report numbness, tingling, or weakness in the affected limb. These symptoms can be misleading, as they closely resemble those of other spinal disorders. Diagnosing piriformis syndrome relies heavily on physical examination. Several tests can help clinicians identify PS, including palpation of the piriformis muscle, the FAIR test, flexion, adduction, internal rotation, the Freiberg sign, the Beatty maneuver, the active piriformis test, and the PACE sign. Each test is designed to reproduce the patient's pain by stressing the piriformis muscle and sciatic nerve. A positive result often means the patient experiences buttock or sciatic pain during the maneuver. However, none of these tests are definitive and results can vary. One of the biggest hurdles in diagnosing piriformis syndrome is the lack of a single, reliable clinical test. Many symptoms overlap with other conditions, and there's no universally accepted gold standard for diagnosis. Even local anesthetic injections into the piriformis muscle, sometimes used as a reference test, lack strong validation. As a result, PS is often a diagnosis of exclusion, meaning other causes must be ruled out first. This makes it essential for clinicians to be thorough and consider PS when patients present with persistent buttock or sciatic pain. Additional imaging methods like MRI and CT scans are often used to rule out other causes of pain, such as lumbar disc herniation or facet arthritis. However, these techniques are not always effective in directly identifying piriformis syndrome, as findings can be nonspecific. Advanced imaging such as magnetic resonance neurography (MRN) offers more promise by visualizing nerve inflammation and structural changes. Still, even MRN has limitations in sensitivity and specificity, making it just one part of a comprehensive diagnostic approach. Anatomical differences in the relationship between the piriformis muscle and the sciatic nerve can significantly affect the likelihood and presentation of PS. For example, in about 17% of people, the sciatic nerve passes through or above the piriformis muscle, rather than beneath it. These variations can increase the risk of nerve compression and complicate diagnosis. Understanding these differences is crucial for both clinicians and patients, as they can influence both symptoms and treatment strategies. Most cases of piriformis syndrome respond well to conservative treatments. Physical therapy is often the first line of management, focusing on stretching and strengthening the piriformis and surrounding muscles. Corticosteroid injections may be used to reduce inflammation and pain. In some cases, botulinum toxin (BT) injections are considered, especially when other treatments fail. Surgery is rarely needed, reserved for severe or persistent cases. Early intervention with these methods can prevent chronic pain and disability. Recent studies have shown that botulinum toxin injections can significantly reduce pain and improve function in patients with piriformis syndrome. MRI studies reveal that after BT injections, the piriformis muscle becomes thinner and less voluminous, with increased fatty degeneration. These changes are associated with pain relief and improved mobility. The effect of BT is dose and time dependent, and image-guided injections help ensure accuracy and safety. This approach is especially useful for patients who do not respond to standard treatments. fMRI/HMRI is increasingly used to diagnose piriformis syndrome. Two key markers are the piriformis muscle cross-sectional area, PMCSA, and thickness, PMT. Studies show that both are significantly larger in patients with PS compared to healthy individuals. A PMCSA above 611.672 is highly accurate for diagnosis, with 75% sensitivity and specificity. These objective markers help distinguish PS from other causes of sciatica, especially when disc problems are not present. Magnetic resonance neurography, or MRN, is a specialized imaging technique that highlights nerve signal abnormalities and structural changes. Unlike standard MRI, MRN can directly visualize nerve inflammation and swelling, making it particularly valuable for detecting nerve entrapments like piriformis syndrome. Case studies show that MRN findings often correlate with clinical symptoms and can be used to monitor treatment response, such as after botulinum toxin injections. Notable case involved a 64-year-old man with severe gait issues and classic PS symptoms. MRN revealed an inflamed sciatic nerve and a swollen lumbosacral plexus. After an ultrasound-guided botulinum toxin injection, the patient's pain and mobility improved dramatically. Follow-up MRN showed reduced nerve swelling and muscle volume, confirming both diagnosis and treatment success. This case highlights the value of advanced imaging in both diagnosing and tracking recovery in piriformis syndrome. Musculoskeletal ultrasound is emerging as a convenient and cost-effective alternative to MRI and MRN. It allows real-time visualization of the piriformis muscle and surrounding tissues, making it possible to diagnose PS quickly and guide treatments like injections. Studies show that MSK-US is reliable and can help clinicians confirm the diagnosis, start early treatment, and reduce the risk of chronic complications from delayed care. Combining anatomical studies with MRI imaging has improved our understanding of piriformis syndrome. Research shows that the sciatic nerve most commonly passes beneath the piriformis muscle, but in 16% to 22% of cases, it passes above or through the muscle. These variants can lead to nerve compression and symptoms similar to discogenic sciatica. MRI helps clarify these anatomical differences, allowing for more targeted and effective treatment. Despite advances, imaging techniques still have limitations. MRN, for example, has a sensitivity of 46% and specificity of 66% for detecting piriformis syndrome. Some cases of sciatic nerve impingement may be caused by other muscles, not just the piriformis. Small sample sizes and lack of standardized protocols also limit the generalizability of current research. Therefore, imaging should always be combined with thorough clinical assessment for the best results. Given the diagnostic challenges, a multimodal approach is essential for accurately identifying and managing piriformis syndrome. This means combining patient history, physical examination, advanced imaging, and sometimes electrophysiological testing. By integrating these methods, clinicians can improve diagnostic precision, tailor treatments, and achieve better outcomes for patients. This approach also helps avoid unnecessary treatments for other conditions. Ongoing research is focused on improving the accuracy and reliability of diagnostic tools for piriformis syndrome. Larger, high-quality studies are needed to validate imaging markers and refine protocols. There's also a push to develop more anatomically precise terminology and diagnostic criteria, moving away from the broad term piriformis syndrome to more specific descriptors. These advances will help clinicians provide more targeted and effective care. Piriformis syndrome is a frequently overlooked cause of buttock and sciatic pain. Its symptoms often mimic other conditions, making diagnosis challenging. Advanced imaging techniques like MRI, MRN, and musculoskeletal ultrasound are improving our ability to identify and treat PS. However, no single test is definitive, and a multimodal approach remains essential. Early recognition and targeted treatment can greatly improve patient outcomes and quality of life. In conclusion, piriformis syndrome remains a diagnostic challenge due to its symptom overlap with other lumbosacral conditions and the limitations of current imaging techniques. Clinicians should maintain a high index of suspicion for PS in patients with persistent buttock or sciatic pain, especially when standard treatments fail. By combining clinical expertise with advanced imaging and a patient-centered approach, we can improve diagnosis, guide effective treatment, and ultimately enhance patient care.